Hello and welcome to Season 2 of Keep It Science. We are back and with a bit of a twist. This time we are shining a light on rare diseases, from insights from biotech leaders and specialist clinicians to personal stories from the people impacted the most. Now, we say rare, but over 300 million people live with rare diseases. That's roughly about 1 in 20 people face years of diagnostic journeys with limited treatment options and struggle with diseases for the rest of their lives due to a lack of a cure.
I'm Dr Elisabeth Kugler, and for me this season is incredibly personal. I have myself a rare autoimmune disease, which includes scleroderma, dermatomyositis, and secondary Raynauds, which is called an overlap disease. And so as a scientist and rare disease patient, I hope to contribute insights from both of these worlds in this season.
And I'm Dr Nick Gorn, and together with Elisabeth and a variety of guests, we'll explore everything in rare diseases, the science, the stories, the struggles, and most importantly, these exciting breakthroughs that we're seeing every single day.
Hello and welcome to Rare Diseases Don't Come Alone. In this episode, we will explore the fact that rare diseases often don't come alone, as they are very often associated with secondary diseases or infections. Today, joining us is Sue Farrington, and she's the president of FESCA, the Federation of the European Scleroderma Associations, chair of PIF, the Patient Information Forum, co-chair of RAIRDA, the Rare Autoimmune Rheumatic Disease Alliance, and she's also the chief executive of SRUK, the Scleroderma and Raynauds UK charity. So welcome to you, Sue.
Thank you for inviting me.
It's great to have you. And a little later on, I will be speaking to Dr Jesus Zurdo. He is the director of Ara Biosciences. He's a leukemia survivor and patient advocate. He's a non-executive director of Telomere Therapeutics, and he's a member of the expert jury at the EIC Accelerator program. So thank you also to Jesus for joining us later today. So firstly, Sue, we're going to speak with you, and it's really a great pleasure to have you here because you're obviously the absolute expert on all of this. And so it would be great if you could set the scene for our listeners and speak with us a little bit about, the secondary diseases that are associated with rare diseases in general and why people should care about them.
When you first mentioned secondary diseases coming with rare diseases, I suddenly thought to myself, we don't often think about it like that. We look at it as the primary condition, and then we look at some of those other issues almost in isolation. And that for me is a big thing. And I'm going to come on to talk about it later, about how perhaps the current medical model is not working as it should. And I think when you start to look at rare conditions, they are a beautiful example of how we should be doing things differently. So when you've got a rare disease, actually it often is associated with another medical condition or with psychological issues or issues around function and mobility. And they can either happen as a result of the primary rare disease, or through the whole diagnostic process or the very drugs and therapies that you're taking to help you get better. And I think if I give the example of systemic sclerosis, which is an autoimmune disease, actually the very nature of that means that you could have infections because your immune system is already compromised. And then when you think about the drugs that you're taking to help manage the symptoms, they too can have an impact on your liver or your kidneys as they struggle to kind of deal with those often quite toxic side effects. And then there's what I call the silent, unseen conditions. And I'm talking about mental health here. Anxiety and depression, and that again is caused by a myriad of issues and reasons, not least the very stressful kind of diagnostic odyssey that many people with rare diseases kind of go through. And then obviously there's another thing, the potential loss of function. Often people talk about their mobility is affected or their hand dexterity is affected. And that actually impacts on your ability to do seemingly simple everyday tasks. And with that, you get the sense of isolation, that psychological burden. You may lose your job as a result. You may have to retire early. You may have to rethink your entire career. And all of these impact on a person's quality of life. But I think what's happened in modern medicine is that we've often tended to ignore that interplay between the body and the mind. So there are many of these, what you'd call associated as secondary conditions, that often get overlooked and they go undiagnosed. And that actually has really got to change.
Thank you so much for that great summary. Yes, absolutely. So I myself have systemic sclerosis and many secondary diseases and conditions that come with it. And I think one thing that you mentioned is this unseen issue that people don't really understand. For example, the impact of drugs when you take them and you just feel really unwell because of certain side effects, or as you say, the loss of function and the sense of isolation. And I think also what you picked up on is that lots of rare disease patients or chronic disease patients lose their jobs or have to completely change jobs, or they can't work because also looking after your health will be becoming kind of the main focus of your life and you're trying to kind of survive. So there's lots of different aspects that play into that. And I think that's really, really important to kind of really emphasize that it's not just your primary disease, but there's a whole kind of rattlesnake attached to all of this. So that's great. Thank you to really set this scene so widely. That's really important. And also, I know in this preparation for the episode today, we spoke obviously about Raynauds, which is also one of the things that you cover with the SRUK, so the Scleroderma and Raynauds UK charity. And Raynauds is something that might be familiar to some of our listeners, where they know that their kind of hands change color, but some of them might not know what it really entails and that it sometimes can be very severe. So maybe you can talk with us about Raynauds and why specifically Raynauds can be a little bit more severe than people might think about it.
I think a lot of people have probably not heard of Raynauds, and that's not just members of the public. I mean, I think medical professionals have, but they have quite different view of Raynauds. And for people who don't know what Raynauds is, it's where the flow of blood to your extremities, that's your fingers and your toes or your nose, becomes compromised, and the body is overreacting to cold, or stress can be a big factor for bringing on a kind of Raynauds attack. And the tiny blood vessels start to constrict, and that stops the flow of blood. And that's why you see the color changes in people's fingers when they go from kind of white to kind of red or purple. And for people who don't have it, the color change isn't the only thing. People's fingers go numb and they get tingling. And as you can imagine, that really severely impacts your ability to do simple things like we've heard, buttoning up a shirt or putting your key in the door. The blood does return. And actually, as it comes back, people describe a burning or throbbing sensation, which, it is absolutely awful. Somebody once said that their Raynauds have got so bad that they sometimes just wanted to chop their hands off. So that's the kind of severity. So the frequency that that kind of losing the flow of blood and it coming back is called a Raynauds attack. And the length of time that occurs differs from people to people, and the frequency also varies. I think the interesting thing, and people are shocked by this, Raynauds affects up to 10 million people in the UK, and it is so poorly understood and is quite often not dealt with seriously by doctors, because in and of itself, it isn't life-threatening. Now, for many of those 10 million people, it won't affect them seriously. They can deal with it, they can manage it, and that's called primary Raynauds. But for a distinct group of people, and it's around 300,000, they get these attacks far more frequently, far more seriously, sometimes leading to kind of digital ulcers on their fingertips or their toes. And that's called secondary Raynauds. And it indicates that there is potentially an underlying condition, such as the rare rheumatic diseases, systemic sclerosis, Sjogren's, lupus, myositis, or it could be some of the rare cancers. And indeed, some of the medications, such as anti-migraine, beta blockers, and chemotherapy agents, they also kind of create that Raynauds and impact the vasculopathy. And there are occupational factors, such as the exposure to vibrating machinery, which can bring on a Raynauds attack. And if people are bothered, then they can go and see healthcare professionals such as rheumatologists, and they are able to tell you whether it's primary or secondary Raynauds. The challenge, of course, is getting a referral in the first place. And that's something at SRUK that we're really working on, because we've recognized that Raynauds is a really, really important symptom and an early sign that shouldn't be ignored when you're getting multiple attacks and they're very severe.
Yeah, also at this place, I want to shout out to SRUK for all the great webinars that you're doing. So if someone has any queries and kind of maybe wants to learn a little bit more about Raynauds, there's lots of great webinars on the SRUK website, lots of general information. If you're not into webinars, there's lots of text as well. So absolutely go there and have a look. There's so much great information. And yeah, so for me, myself, Raynaud's was one of the first symptoms. And so for me, it's mostly kind of this loss of sensation, like my legs, for example. One of the things that really impacts me the most is that when I'm really stressed or if I'm cold, I can't feel my legs whatsoever, which means I can't drive, I can't walk, anything like this. And I think, like you say, that's really severe, obviously, but also if you just lose like sensation in your fingertips and you can't, like you say, close a button, pick up a coin, lock the door, it's all these little things that, really impact daily lives. Because, for example, if someone is in an office and writing and someone else turns on the aircon, that can be really a problem, right, for working. Because also, obviously, temperature has a huge impact, which is also something that you are trying to raise awareness about, especially in the UK. We have these issues with heating prices going up quite a lot. And I know that you're trying to raise awareness with SRUK that, especially with Raynaud's, temperature needs to be higher, right?
Yeah, no, it's really important if you do get Raynaud's that your temperature is set at a kind of steady 18. And when we hear from some people when the cost of living and the energy crisis was really hitting people hard, they were having to make decisions between eating food or having their heating on. And, in a country like ours, that is not acceptable. But we often hear about the thermostat wars, and you mentioned air conditioning too, because when it gets hot, that's the first thing that we want to do. We want to put the air conditioning on. And actually, we have somebody who works in our office, one of our members of staff, she has Raynaud's, and we're all desperate to have the aircon on, but we're very conscious that for her, it brings on a Raynaud's attack. So we have created a whole series of publications aimed at employers, aimed at schools, because primary Raynaud's can particularly affect younger people. And, if they're doing exams and there's a combination of the cold and the stress, then it's really important that schools and employers understand the kind of reasonable adjustments that can be made to support people with Raynaud's. So those publications are available on our website.
And you also brought up reasonable adjustments, which is something really, really important. And I think also someone kind of maybe at the start of their disease journey, they might not know what that is. So if you don't know reasonable adjustments, make sure, again, to go on the SRUK webpage or other trusted resources and look them up, because it's really, really important to get the help that you need for your work as well. And so now I want to change gear a little bit with you, Sue, namely to treatment challenges. And I know there's many of them, especially with rare diseases. There's long diagnostic journeys that you mentioned, but also insufficient data, very high treatment costs. And you mentioned also access to specialists can be very challenging, and especially with rheumatology and seeing a specialist rheumatologist, this can be very, very challenging. So maybe you can share with our listeners why this is and how they can get the treatment that they might need.
So for rare rheumatic diseases, like many rare diseases, there are many challenges. And the first one is actually getting a diagnosis. Because they're rare, it does mean that general practitioners may never have come across some of these conditions before. So they've got limited knowledge. But when you add into this that many of the first presenting symptoms are quite common, like acid reflux, like Raynaud's, sore, swollen joints. They're very similar to other conditions. So for the GP who may never have come across systemic sclerosis, trying to make sure that they refer to the right place is the first challenge. And so we did a survey recently and we found that over a third of people, it took them 5 or more years to get that diagnosis. So we really are working hard to kind of bring awareness of the red flags. Systemic sclerosis, I think, is in a more fortunate position than some of the other rare rheumatic conditions in that there are some really clear signals. Those are the ones I mentioned: sore, swollen, puffy fingers, acid reflux, and Raynauds. So if anybody has got that combination, you either go to your doctor, or if you are a GP, you go, oh, okay, refer to rheumatology, not to dermatology or respiratory physician. Because interestingly as well, sometimes people present with breathlessness and they're referred to a respiratory physician, who may never have dealt themselves with systemic sclerosis. It is an incredibly complex disease. And because it affects a number of organs in the body, that adds another layer of complexity. So when you do get a referral and you get a diagnosis, then the next challenge is actually making sure that if you are affected in different ways, like your GI tract or your lungs, you have that proper coordination of care, and that can often be missing. And as you mentioned, actually, getting referred to a specialist is also really challenging because there are fewer of them, and rheumatology is going through a bit of a crisis itself in terms of workforce recruitment, and that's particularly very visible in the rare disease space. So there are a number of challenges, and the biggest one, I think, is that there is no cure. But what we have seen over the last 10 years is a real increase in the number of disease modifying therapies that are available. They don't roll back any of the destruction that's happened. They don't cure it, but they help people to kind of better manage the condition.
Yeah, thank you so much for that insight. And so you mentioned disease modifying treatments that have especially developed in the last few years. Can you maybe speak about one of them that really excites you and where you're like really hopeful that, or you already have seen maybe, that there is a lot of change for patients and their quality of life?
So 50% of people with systemic sclerosis are affected, they have their lungs affected. And there's been a lot of interest in that space. There is a particular therapy developed by Boehringer Ingelheim called nintedanib, which has been shown to be incredibly effective for the fibrosis that occurs in the lungs. So I think that's one of the exciting developments. There's also real progress in pulmonary arterial hypertension, because that's another area that impacts patients with systemic sclerosis. And I would say, 5 years ago, it was quite limited, the number of therapies that were available, but there is real progress and, new clinical trials taking place in the space. When I first started with SRUK, I think there were 3 pharma companies really kind of engaged in the space. There are now 35 clinical trials taking place. So this is really exciting.
Absolutely. No, that sounds great. And really, it gives so much hope to patients that there is interest, that there is also financial backing from industry and really kind of resources being put into it. That's great to hear. And later on in this series of the podcast, we will also be speaking to Professor Ellen Laurie, who is actually a pulmonology expert. So we will probe him on all of this, absolutely, which is great. And another thing that you mentioned is rheumatology recruitment issues. So maybe you can speak a little bit about what advice you would give to a young researcher or clinician who's interested in rare diseases but doesn't quite know how to get into this space or maybe who to contact.
Do you know, I think it's really interesting. Rare diseases, as we've said, don't come alone. And that's, I think, where the fascination is. It is complex and it does affect so many different organs. And to me, that complexity is what makes it so interesting. Because if you're going to research in this space, it means that you maybe unlock or discover secrets that don't just affect one condition, but can have that kind of ripple effect or that amplifier effect to other conditions. So you may start your research with one issue, but actually, because it is such a complex area, I think very soon you start to see through the mechanisms that understanding those mechanisms could have significant effects or understanding for other disease areas.
Yeah, absolutely. And that's also something that we want to speak with Jesús later about, of like off-label use with drugs and, for example, label expansion, because like you say, maybe there's a medication that is applied to one situation, but we might be able to use it for something else, like, I don't know, aspirin or something like that. So we will definitely come back to this. So yeah, it's really interesting. And like you say, it's so complex that I think working in that space is like a huge problem solving situation, but there's many different associations that obviously kind of started with this and where people can kind of contact them and start working with this. So it's really great to hear that.
I think from this whole kind of off-label and then the label expansion area, I think is a really challenging one for rare diseases. It's exciting, but I think there are real challenges. So if we take the kind of off-label medication use, one of the challenges that we've seen happen is the information dissemination. So if you're in a specialist centre, you will be across all of the key things that are happening. But if you're a general rheumatologist in a general setting, you may not have access to this information. Maybe it's because you don't treat enough people. So there is huge potential for that to happen. And then obviously, if we come to the label expansion, I think the challenges for rare diseases are the small population sizes, trying to get a sufficient number of people with a particular disease so that you can recruit for an effective clinical trial. I think that poses real problems, but hopefully there are solutions, and maybe your next guest can highlight some of the ways that we can get around that.
Yeah, absolutely. And one thing that you also mentioned is that issue of centralizing information. I think that is something very, very interesting because, like you said, there is so much information, and I think that is often a challenge. And you are part of many different associations, so maybe a little bit off record, I can ask you, kind of what are some steps that you would recommend to centralize information, especially also on like an international level even? I know there's differences of treatments, etc. So there's many levels of complexity, but maybe what would be your like top tip to centralize information if we could do it?
I think the frustrating thing is that there already are a number of groups and organizations that perform that function. So it's more a question of helping to increase their visibility. So there is the World Scleroderma Foundation that has, a fantastic repository of information and knowledge for clinicians and patients. Communication, I think rare diseases, particularly in rheumatology, as you've perhaps indicated, are not necessarily attractive to young, ambitious clinicians or researchers coming through. And I think when there is that lack of interest, that also kind of compounds the lack of awareness that we have. But there are places like the British Society of Rheumatology. There are places that clinicians can go to. I think one of the things that I've seen that is really helpful and everybody should look at are the best practice guidelines. And both in the UK and in Europe, they've recently been refreshed. And that was something that I was going to talk about later, about when we talk about patient power, because patients were involved in the updating of those guidelines. And if nobody was to look at anything else, going to those best practice guidelines is the best place to start.
That is perfect. So maybe you already want to speak now about like how patients, can contribute to rare disease research and also how you involve them in the research that is happening.
Do you know, one of the things that I've seen since I started with SRUK is a real shift in the way that patients are engaged and the role that they're playing in policy, in research, and in clinical practice. I think what I've witnessed is that there's a far greater acceptance from clinicians and policymakers that actually patients have a significant amount to contribute about their experience, about the condition, and particularly when a condition is rare, the patient knows their body better than anybody else. And so moving towards a kind of landscape where we have respect for the lived experience alongside the learned experience, I think I'm seeing that happen more and more. Don't think we're quite there yet. And I think there's certainly a lot more that we can do to improve communication skills. But I think the more empowered patients are, then the more information they're going to be taking to their physicians so that they enable and prompt that conversation. But if we're looking at the role that patients can play in the policy space, actually what we've found is that it's much more effective when we work collectively and collaboratively. And in the UK, we have, as you mentioned earlier, the Rare Autoimmune Rheumatic Disease Alliance, fortunately shortened to RAIRDA. And we've worked really effectively across the several rare rheumatic diseases, which I think has helped to get us a seat at the table with the Department of Health, with NHS England. They'd far rather talk to a collective than 8 different patient organisations. And I understand that. And in Europe, actually, we're solely focused on systemic sclerosis because that is about us empowering and embracing patients across such a wide landscape. We have to focus down on one single condition area. And one of the things that we've done is work with patients to gather insight and data on their condition, their experiences, so that we can plug that into policy papers. Patients are able to identify gaps, be they in treatment areas, either drug therapies or the non-pharmacological. And I think those areas that we've identified have been really well received by the European Commission, the European Parliament. So I think patients can play a huge role. And I think, as I mentioned earlier, I think they can also have a direct impact on the clinical practice. And we saw that when patients were involved in the review of best practice guidelines. They know what the real world challenges are and what the impact of having some of those drugs are, where the gaps are in treatment, where people aren't focusing down. And I have to say, the one thing that came out loud and clear was the lack of access to psychological support. And I think we're going to talk about that later, aren't we?
I think that is so important. And I'd love to kind of already pull that to the front and talk about that now with you briefly, because I think, so you mentioned several things. One of them is patient knowledge, which is something that I'm always like astonished about. If I talk with other patients about, their knowledge about drugs, about the side effects, about, all of these things, it's vast, and every patient has obviously their own knowledge and experience, but the actual, kind of science knowledge that people have is absolutely astounding, because they need to know, right? They need to know what is a drug doing, what is the side effect, what might be the trajectory of their disease, etc. But also the patient's kind of own management, how they, for example, handle the cold during the day with Raynauds, or for example, how they handle being nauseous on a drug, etc. I think all of these things in the patient's own management are really important. But as you say, also psychology is a huge aspect. So maybe you can speak to, the psychological support that is needed, especially, early on. I think after a diagnosis is so important. So maybe you can speak to that a little bit.
So one thing that came through loud and clear in all of the surveys that we've done is how rare diseases, rare rheumatic diseases impact on people's mental and emotional well-being. And yet there is very little focus given to that area. And often it's because it doesn't come up in conversation, because people, this is where I come back to communication and the real importance of communication. Physicians are time limited. They're not having those conversations. They're not saying they're not sometimes even giving that space for a patient to truly start to talk. And I think when a patient starts to do that, the physician will maybe start to connect the dots and understand that they're anxious, they're depressed. And this can have all sorts of ramifications for the way they are interacting, the way they're handling their life, maybe even their adherence to their therapy regime. And that, is tantamount. So I really honestly think that we've got to relook and we've got to integrate mental health care into that package. People don't have to have it, but if it can be offered and if it can be available. And one of my major frustrations is that it's already been demonstrated through several condition areas, long-term conditions, that things like CBT can be hugely powerful and beneficial to patients. And yet, when somebody has been referred for access to that therapy, the clinicians have been told, sorry, no, we can't provide that, because where is the evidence to show that it works for systemic sclerosis? Now, to me, that is mad. Why would we take every single long-term condition to demonstrate that things like CBT work? We know they work. I know it's probably a payer putting a financial barrier in the way because of finances, but actually that's so short-sighted. The more we can support people early on, the better people are going to be able to cope in the long term.
Couldn't agree more. I'm just sitting here and I'm like nodding. I'm like, yes, absolutely, yes. Because I have to say, for me, I was very, very lucky. My GP, it was one of the first things that he said, do you want psychological support? Do you want CBT? And I said, yes. And I think especially once you're diagnosed, I was 30 at the time. I was completely overwhelmed, I have to say. It was during COVID. And I think I was in shock, to be honest, because my whole life had changed and my kind of abilities completely had changed. Having CBT, I mean, it was major support, right? And I think even just having that opportunity to talk things through and, what's coming to you and like the changes, and just being able to say to someone, I do not know what to do. And having that space is sometimes, all you need to kind of make that first step in that journey. So yeah, I think it's absolutely, undervalued. And yeah, I hope that patients have as much access to it as possible. I really hope that that's the case.
And often people talk about a sense of isolation.
Yes.
But you were in a situation with a double whammy. You were isolated through COVID. So that added, another layer of kind of complexity to it. So I'm really pleased that you got access to CBT.
Oh God, absolutely, absolutely. Yeah, my counselor was the best, I have to say. And I think also exchanging with other patients is very important. That's also how this podcast topic came about, because we said it's often not the primary illness, but actually the secondary issues that are much more boggling than anything. But we're kind of starting to run out of time, Sue. So I want to just ask you the last question, which is like, what is one innovation or policy change that you would like to see championed?
So there's one policy area that we have been working on, and this was under the auspices of the UK Rare Diseases Framework, where those members of the Rare Disease Forum identified that there was a gap. Their fantastic focus on life sciences, on genomics, which is really, really important, but they might not deliver for 10, 20 years. So there felt to be a bit of a gap in something that might provide tangible benefit in the here and now. The reason the quality standard is so important is that gives something against which people can be measured, and that patients can say, this is what good looks like. This is what I expect from my care. And when quality standards are put in place, it was demonstrated with rheumatoid arthritis, there was a significant improvement in time to diagnosis, in access to treatments. So by having this quality standard, it will take time to implement. We hope that this could really make a fundamental shift to the health outcomes of patients with rare diseases.
That's fantastic. Thank you so much, Sue. It was great talking to you, and obviously I could talk with you for ages, but we have a limited amount of time. So thank you so much for joining me on this episode. It was great to have you. I'm now joined by Dr. Jesus Zurdo. Welcome, Jesus, in this episode. It's so great to have you here today. So in the first part, we spoke with Sue about secondary diseases, but now we get your insight as a scientist, but also patient. And it's really lovely to have that conversation with you. So thank you for joining us. And what I really want to start off with is get really this first insight from you about something that's very personal to both of us, namely the secondary issues that come often with a primary disease. And maybe you can talk with us about, why is it so important to talk about secondary issues and why they sometimes may be unseen, and especially for you as a leukemia survivor and patient advocate, you have such a breadth of insights. So can you maybe share with us a little bit about, secondary issues in general?
Absolutely. My pleasure. And thank you very much for inviting me to the podcast, Ellie. I'm really honored and be given the opportunity to bring my perspective and the patient side. I think it's a great opportunity, and it's something I think we should do more, listen to patients. I think, to your question, the particular issue, and I love how you call it, secondary diseases, is not adverse effects or adverse reactions of the treatment, because they can become diseases. They are diseases. They can be very debilitating. And in my case, we discussed this previously in other occasion, we have the C word takes over the whole approach to treating the patient. So cancer is seen as a very black and white, either you die or you survive. And yes, there's an element of that, but cancer doesn't always manifest like that. And also the treatment can cause many nasty adverse reactions. In my case, because I received a stem cell transplant, then I said, and now I live with two diseases. I started with one and now I live with two. I have a latent pseudo-autoimmune disease that is the GVHD, the graft versus host disease, is the reaction the stem cells from the donor can have against my body. And then a latent cancer that at the moment is dormant but can awake. And to me, it's a great trade-off, because I had an acute cancer in basically I had weeks. So this is great, but it's important that we speak about how treatments can impact patients. And I think there are many reasons for that. One important one is that it helps, I think, the industry and the healthcare industry as a whole just to develop better treatments that address general quality of life aspects that are, for me, very important, and I think generally for patients. You know, we could talk for hours, but I think there in the big, I think, elephant in the room for cancer treatment is the effect of the chemo that has in your brain. And this is something that is buried in the side effects and things like that, but really nobody talks about it. I started talking about it with other patients because I was concerned. It took me forever in the mornings to get ready to be able to process things. And my wife was asking me a question and I had to tell her, can you wait for a minute just before I answer? And she would get impatient, and people do not get why. And it's because many of these medicines are toxins to your brain, and is well known, particularly when you treat children, and they can impair the development of their brains, but it can cause long-term effects. Sometimes it can last for years, sometimes it lasts forever. It's not in the world. It's something that you can manage, but you need to be aware that your acuity, your ability to respond, your ability to have long meetings is no longer there. It's something that is debilitating and is impacting probably your work life and your family life as well. And there are many more. I mean, I just see, just going back to, the effects of the transplant, a GVHD can kill yourself. Your immune system, your acquired immune system can target your liver, your kidneys, your brain, your digestive system, your eyes. And sometimes, and I think this is another thing, is how serious these secondary diseases are. Of course, if you have a renal failure or a lung problem, then it is serious. But I have friends that have, for example, GVHD affecting their eyes, and it's really debilitating because they cannot function. I mean, imagine just having to apply eye drops every 10 minutes, and if you are doing a job that requires, I don't know, reading or paying attention, it can be basically stopping that part of you. So I think it's all down to how this secondary diseases, these adverse reactions impact your life. And not everybody is the same. Sorry, I feel I'm a bit all over the place. Apologies.
No, not at all. And not at all. It's so lovely to get these insights because I think, we have spoken previously about this. There's so many things that people don't see or don't hear about. And I wish I had known lots of these things before I started certain treatments.
Absolutely.
Like, for example, you mentioned drug-induced mental fog, but to that also, again, cognition, memory, problems talking. Sometimes when I have a conversation with someone and I literally just look at them and I don't know what they're saying to me because I completely blank out, right? And it can be really embarrassing, especially if you haven't met that person before, and it can be a problem working. Or, it's just really, really debilitating. Or like you say, especially also in the morning, to kind of get up and get your memory started and not be nauseous and things like that. I think that's the things that are not spoken about. But for me personally, this is also hugely debilitating, as you say, especially if like half of your morning, you just try and, piece yourself together almost, right? And I think that's so, so important to talk about. And the other thing that you touched upon is also, like, for example, immunosuppression or chemotherapy themselves bring in so many side effects that aren't really spoken about. And I know you have both experiences. So with like your stem cell transition.
Transplant.
Transplant, thank you. I knew something with see, words. It's
No.
like words.
Yeah. Absolutely.
So especially during the time when you were immunosuppressed, I know it was even more challenging. So maybe can you share with us your experience during that time?
Yeah, I mean, actually, and this was good. The treatment, I mean, chemo is, when you treat a blood cancer, you kill your immune system. That is, primarily all your B cells need to go in our case. In other cases, T cells. But that means that your immune system is debilitated to a point. I didn't have neutrophils. I didn't have any way of fighting disease. And I remember the nurse when I was discharged the first time, and she told me, Jesus, don't be a superhero. Don't try to be a hero. Cancer will not kill you, at least not yet, but an infection can very, very quickly. And I actually ended up admitted at hospital 3 times during my treatment. The fact that you're immunosuppressed means that you are pretty much very, very exposed to any tiny disease any infection that anybody could, deal with very easily, suddenly can be life-threatening for you. And actually I've been looking at this, following up very closely. The main cause of mortality not linked to cancer in my case, and all blood cancers, I think, is infection. Infection is the main cause of mortality. It's serious, very, very serious. And so this is a challenge, is how you manage yourself, how you manage your interaction with other people. So you minimize that risk. You cannot avoid it completely, but you minimize that risk. I remember having conversations at home with my children, the importance of hygiene, with teenagers, you can imagine, it's not, it's not easy, but also how I manage my relationship with family. So even when I was a bit more, recover after my transplant, having to visit my family, and I said, I would just say the COVID rules apply here. It has to be open spaces. It has to be limited groups. I want to minimize any risks. But the immunosuppression was none of the patients that I met in the clinic liked it. We used to have this tremors. I always say that it was like having Parkinson's. My hands were like this all the time. I could not do any fine things. My wife was saying, "How can you help me trim my hairs that I cannot do with this hands?" I didn't have a strength to grab things, but also generally, I felt, weak, and I felt it did have an impact generally on. It has impacts on nausea. We talk about this sometime. The nausea for me is something that different treatments have caused it, but is probably one of the most debilitating things I've ever suffered. I mentioned this to you. I told my wife, to me, she's a hero now. When I realized she had morning sickness for 4 months with my children. Oh, how on earth women can deal with this? Because for me, was the fact that it was bringing my mood down, and I could not shake it off. It's just embedded in your being. And I remember listening to Cutlery, everything is food. Suddenly, all your universe is food, and I could not go with it. So, this is something that comes as a consequence of treatments, but immunosuppression clearly is one of the biggest challenges there in triggering some of these effects.
It's so interesting to hear you talk. I could listen to you for hours, seriously. But I want to pick up on 2 things. So the first one is boundary setting that you mentioned. And I think that's really important because I'm myself immunosuppressed, and that's something that these conversations are ongoing all the time, especially now winter time is coming, and not only myself needs like vaccinations, but also the people around me. And I think it's very interesting that you say that the COVID rules apply, because I think it really helped people to understand the transmission of infection, as you mentioned, the importance of hygiene, but also that when you are ill, you have to do a lot of education with family, friends, co-workers on saying what you can and cannot do, and also kind of, especially for kind of infection prevention, what is important to you. But also, like you say, it's not just, you have an infection and you bounce back and you clear it, but actually you're ill for longer afterwards because you really need to rebuild strength and every time from zero, which is really exhausting. But the other thing that you also mentioned is like you speak in we terms, and I love that because it speaks for patients, and we kind of hope to represent, a very wide patient voice. And I know for you, patient support is really, really important, and patient engagement as well. So maybe you can talk to our listeners about the importance of that network of patients, but also like the patient engagement in like sciences and pharma.
Oh, wow. This is very, very close to my heart. For me, it has been a big discovery. Actually, I find patients are my family. And this is something I experienced in the clinic, particularly after being in hospital. I was in isolation for a long time. When I started going into the clinics and meeting other patients, it's a forum where we exchange experiences. It's a forum where we support each other. I mean, it was everybody for everybody else. And I've never experienced such a level of commitment before. And it becomes, as I said, a family. I mean, and then it's sad when some of members of a family don't make it. But I maintain that. I remember, people that they had such an impact in my life at many different levels that I'm grateful that I could experience that. Think now with having gone through this journey, I'm a scientist. I've been working in drug discovery and development for years. And I was very lucky at the beginning of my career. I met with patients and I was always amazed about the level of understanding and knowledge these guys had about the disease. But now for me is even more intense because yes, patients might not be aware of the science, although you need to be careful. Some patients, even though they're not scientists, they read a lot. There are patients that don't want to know because it's very stressful, but patients, if they take an interest in the disease, they really want to understand why it's happening to them. And they live with the disease. They understand what is the impact in their lives. They understand, we were discussing before, what is the impact of living with a GVHD? What is the impact for waking up in the morning? You were describing, not finding the words. I remember, that is what is the word for, I could not find it. Or having a conversation with 3 or 4 people, feeling completely overwhelmed. My brain was not able. So that only a patient that has gone through it can experience, can understand, and can communicate that. So it's taken into consideration. So for me, and I think we are fortunate because the industry as a whole is becoming aware of the importance of engaging patients, not only as an end user, but actually as an important stakeholder in supporting the design of better medicines, better treatments. I've seen very interesting experiences. Unfortunately, it's still early days. And this is something I'm fully committed to promote. I see value for every single stakeholder if you can tailor the treatment to address key concerns of a patient. And then not every patient is different. It's not the same having, in my case, acute lymphoblastic leukemia. It's not the same being a 2-year-old than a 50-year-old or an 80-year-old. The outlook is very different. But also the resilience, not only just how the patient is physically, but also what is important for the patient in a given time. Anecdotally, I've read stories about clinicians talking to patients and about, treating, I think it was, I don't know if it was AML or something like that, but it was an acute cancer. And then they were shocked because some patients, they refused treatment. They were elderly patients and they thought, for me, it's not worth going through all this pain being in a hospital for a month or more. I want to be with my family. And that is very respectful. it has to be respected. Now, in my case, it's a different perspective. Of course, I want to be able to somehow survive this so I can extend my life, but also not at any price. And this is a conversation I had with my children and my wife. If the cancer comes back, I have some conditions, not at any price. I want to enjoy some quality. So I think this is important when you develop treatments, that you address what is important for patients. Sometimes we focus too much on the clinical markers, but not what is to live with the disease. If your disease brings fatigue, then for you, success is to be able to climb the stairs, to be able to do the shopping, to be able to have time with your friends. And maybe some of the other markers are not that, resolve, but that for you is important because it makes you feel, more connected. It makes you feel functional. So that is an area I think there's more that we can do about, but also it can bring value. It's shown to bring value to developers. It shortens development time, increases the chances of your treatment to be approved. For investors, also increases the chances of your investment be successful. If you are developing treatments that really address patient needs, then it's less likely it would fail because it doesn't cause the desired response. So yeah, again, I keep rambling a bit. This is for me a key thing and very, very important right now. And it's something that I think we could do more and is going to be beneficial if we listen to patients more.
It's an absolute privilege to listen to you. Seriously. I really enjoy our conversations in general, but also having you here is really a privilege. And especially the last few episodes, we interviewed clinicians. And in our last episode, I kind of tried to have a patient conversation with my own clinician, which was hosted by Nick, which was really nice. But having really this patient-to-patient conversation is really different because you add this perspective of a patient. That's the thing that really matters, like you say. And I think quality of life is so, so important. Like you say, it's not just about, about X or Y. There's so many more things. Like you say, can you go up the stairs? Can you go shopping? Can you wash your hair? Can you, what is the kind of things that you can and cannot do? And I think that is something that, again, if you haven't gone through, is probably very difficult to see. I know for quite a while, my partner had to wash my hair, dry my hair, do everything. And I was literally, I couldn't even step into the shower. I was just like, completely drenched and I was, not able to do anything. And I think, having this conversation is so, so important because not only do you touch on, quality of life, but also having your own boundaries of knowing what can you take and what can you not take. And I think especially when you are ill, you have to deal with so many things, right? Appointments, physiotherapy, dietitians, the treatment itself, the side effects, managing your family. And with all of that, it's just, when is it too much, right? And I think what people often don't see is that we spend so much time on actually kind of managing the disease or actually being in hospital, that this in itself is really a burden. And especially, I know, like, there was a time when I got so many letters for appointment through the post that I was just like, I cannot open them. I was so like, I cannot deal with this. And so I said to my partner, please, just deal with it because I can't anymore. And I think that is really important to have this, when is it too much and when do you set these boundaries? And I think one very important thing is obviously this emotional toll that it has, and that is often not talked about. So maybe you can share with us, your insights on...
I really love what you describe about your experience and your partner. And I think the partners or the carers are the unsung heroes here. I always said when I was in the clinic, you could tell, of course you could tell some people without hair, whatever, but the partners, the expression in their eyes sometimes was really telling. I keep saying that probably they have a harder time. In my case, I knew what my journey was and it was taking or leave it, but I was in the treatment. It was impacting me. I was off sometimes. I didn't have any energy, but that was it. My wife was sitting there and, seeing me completely gone. I remember one of the chemos that would just knock me off. I could not talk. I could only breathe. And she was worried to death. And she was not able to do much. But also, as you said, you're in hospital and the support, which is so important for patients. Having somebody that comes to see you, I mean, that is the best gift you can have, or somebody giving you a call, bringing you food or whatever, things that help you with the nausea. And that is priceless, but that takes a toll on your partner. They need to take time off work. Sometimes after work, they had to, do lots of things. They need to prepare, they need to shopping, all that stuff. And they need to do the work, and they need to do the admin, as you said, taking care of appointments. Are you sure are you on top of things? And there's a point where I was managing myself, but she was basically the safety net. And often they don't take care of themselves. I mean, it's like they need to be the strong party, and they can crumble. And I see this often. Unfortunately, it can take a toll on the person, but also on the relationship. So yes, I mean, it's emotionally it's draining having a disease that, I mean, in your case and in mine is for life. But the process, the treatment, it took years, and it's not like it's an intensive treatment. You have chemo and then that's it. Well, no, it's just this. Yes, you have the strong chemo, you have the second, the third round, and then you have your stem cell transplant, and you have the recovery, and then oops, you have an episode of GVHD. Oops, now you need in my case, I needed additional infusions, and it extends. So you need to equip yourself. It's a marathon, but a marathon that has no end. So you need to equip mentally. Is that right? We keep going, and having tools to vent the frustration and to find. It's not all about the disease. You need to find channels to find enjoyment and to talk about the weather or whatever, but also to be able to talk about the disease without that worry. Is just part of your life.
But there's so many gold nuggets that I could be talking with you about for ages, Jesus. But unfortunately, we are running out of time. So I have to thank you so much for joining us. And it was an absolute pleasure. You have now heard from Dr. Jesus Zurdo from Ara Biosciences and Telomere Therapeutics. Earlier, we've heard from Sue Farrington from FESCA, PIF, RAIRDA, and SRUK. And so if you want to learn more about both of our guests, you can head to their websites and find them on social media. We will make sure to link them across all the different accounts and platforms, and we will make sure that we have all the episode details for you at hand. And so to our listeners, thank you so much for tuning in to this episode, Rare Diseases Don't Come Alone. And make sure to stay tuned in for our next episode, which is coming soon. So thank you so much. Bye for now.
Thank you.
This podcast was produced by Keep It Science, a collaboration between Acorn Scientific Marketing and Zeke's Art for Geeks, two award-winning science communication and marketing agencies based in the UK. If you enjoyed the episode and you're thinking about launching your own podcast, whether it's to share some expert insights, tell your company's story, or build market presence, we'd absolutely love to help you create a podcast with outstanding science and production quality.
Drop us a line at keepitscience@gmail.com, find us on LinkedIn, and if nothing else, keep it science.